Welcome to all. Today I shall discuss the salient points of anemia. Regarding the clinical features of anemia, it is fatigue, paleness, yellow skin in hemolytic anemia, dark urine in hemolytic anemia, shortness of breath, dizziness, cold extremities, palpitation, anginal chest pain, sore tongue, cognitive disturbance, memory loss, and confusion. What about the physical finding? Pallor, jaundice in hemolytic anemia, glossitis in iron, cobalamin, and folate deficiency, tachycardia, soft systolic murmur, splenomegaly in hemolytic anemia, petechiae purpura ecchymosis in aplastic anemia, diminished muscle power. Specific clinical features associated with different types of anemia. In iron deficiency anemia, spica, that is craving for non-food substances like clay, dark ice, koilonychia, that is spoon-shaped nail, glossitis, angular stomatitis. Megaloblastic anemia, glossitis, angular stomatitis, peripheral neuropathy, that is tingling and numbness in hands and feet, muscle weakness. In hemolytic anemia, it is leg ulcer, gallstone, jaundice, splenomegaly, and sometimes hepatomegaly. Aplastic anemia, it is petechiae, purpura, ecchymosis. What are the signs for detection of pallor? It is lower palpebral conjunctival region. It is the tongue, nail bed, palmar region, especially the palmar creases. The associated feature of anemia, glossitis, angular cheilitis, both are present in iron deficiency anemia and megaloblastic anemia. Koilonychia present in iron deficiency anemia. Here we see the RBC development from the hematopoietic stem cell developing into proerythroblast, early erythroblast, late erythroblast, normoblast, finally reticulocyte and the erythrocyte. Before knowing the topic of anemia, we have to know about the reticulocyte. As we have seen in the previous slide, the stem cell, hematopoietic stem cell developing into erythroblast, normoblast and finally reticulocyte. Reticulocytes are premature RBC which are coming into the circulation, and we have to know about the reticulocyte. This reticulocyte count is average 0.5 to 2% of the total RBC count. For classification of anemia, it is better to depend upon the reticulocyte production index. How to measure? RPI is measured by reticulocyte count into ratio of hemoglobin percent divided by 15 and 2. This reticulocyte production index is usually 1 in stable state, but it is 2 or more in case of anemia. Come to the laboratory test for anemia diagnosis. First is the CBC or complete blood count. Under this heading, it is RBC profile, RBC index, RBC morphology, WBC profile, and platelet count. Under the heading of RBC profile, that is total RBC count, hemoglobin, hematocrit, and reticulocyte count. Under the heading of RBC index, it is mean cell volume, mean cell hemoglobin, mean cell hemoglobin concentration, and red cell distribution with that is RTW. Then the RBC morphology, then come to the WBC profile, total WBC count and differential count, and finally the platelet count. Next come to the body iron profile. Under this heading, it is serum ferritin, serum iron, and total iron binding capacity. Next is the serum vitamin B12 and folic acid distribution. And fourth parameter is the marrow examination, this is marrow aspirate and marrow biopsy. We have to know few salient points regarding anemia. As per WHO, it's the hemoglobin less than 13 gram per deciliter in male and 12 gram per deciliter in female is anemia. Hemoglobin percent less than 8 gram per deciliter in male and less than 7 in female is severe anemia. Mean corpuscular volume determines the RBC cell size. When it is more than 100 femtoliter is macrocytic RBC, but when it is less than 80 femtoliter is microcytic RBC. Mean corpuscular hemoglobin or mixed corpuscular hemoglobin concentration determine the hypochromic RBC. Next come to the anemia classification. Depending upon the reticulocyte production index, we can divide the anemia in broad two headings. When RPI is less than 2 and another side RPI 2 or more than 2. When RPI less than 2, it is non-hyperproliferative marrow response. Under this heading, nutritional deficiency, that is iron deficiency, cobalamin deficiency, and folate deficiency. Next is the erythropoietin insufficiency, as in chronic kidney disease or in chronic inflammation. And third one is the marrow insufficiency. What is the RBC pattern in deficiency category? The RBC is normocytic normochromic in early iron deficiency, microcytic hypochromic in advanced iron deficiency, macrocytic in cobalamin and folate deficiency. Now come to the erythropoietin level. In this case, RBC is normocytic normochromic. For marrow insufficiency, RBC is normocytic normochromic. Now come to the RPI 2 or more than 2. This is hyperproliferative marrow response. Under this heading, two broad categories, chronic hemorrhage and hemolysis. Chronic hemorrhage is the picture of severe iron deficiency. RBC is microcytic hyperchromic. Under the hemolysis, we will get hemoglobinopathy, that is thalassemia, sickle cell anemia, enzymopathy, membranopathy, paroxysmal nocturnal hemoglobinuria, hemolytic uremic syndrome, toxin, venom, drugs, and so on. And RBC usually normocytic normochromic, but in case of thalassemia, it is microcytic hypochromic in nature. Now come to the discussion about the percentile distribution of anemia. Out of total anemia, iron deficiency anemia is the commonest type of anemia, 50 to 60% of the all. Next is the anemia of chronic disease. Chronic disease including chronic kidney disease and inflammatory anemia, 25 to 30%. Vitamin B12 and folic acid deficiency anemia, 5 to 10%. Hemolytic anemia, 1 to 33%. And marrow failure anemia, 1 to 2%. Let us discuss about the iron deficiency anemia. Daily need of elemental iron for adult male is 10 mg and adult female is 15 mg, of which 10% is absorbed. Iron absorption largely occurs in duodenum and jejunum. Iron rich food, heme iron, animal based meat, liver, poultry, fish, non-heme iron, plant based, dark leafy greens, legumes, nut, dried food like apricot, resin. Phytate and phosphate present in the vegetarian foodstuffs reduces iron absorption by 50%. Iron status marker by serum ferritin, it replaces the body iron store, serum iron, total iron binding capacity, and transferrin saturation. Diagnosis of iron deficiency anemia. Anemia usually mild to severe, mean corpuscular volume normal to low, low means less than 80 femtoliter, mean corpuscular hemoglobin normal to low, that is less than 27 picogram, mean corpuscular hemoglobin concentration normal to low, that is less than 31 gram per dl, ferritin serum less than 15 microgram per liter, less than 30 indicate iron deficiency, but when less than 15 it is specific. TIBC more than 360 microgram per deciliter, RDW more than 14.5%. RBC morphology in the early stage is normocytic normochromic, in the advanced stage it is microcytic hypochromic. There is anisocytosis, means variable size, and poikilocytosis, that is variable separate RBCs. This is the picture of variable size RBC, that is anisocytosis. The picture of variable shape RBC is poikilocytosis. Now come to the stages on iron deficiency anemia. First stage, the negative iron balance. The starting of depletion of the body iron store, the serum ferritin is decreased, that is less than 20 microgram per liter. TIBC is increased, but serum iron and aspirin saturation is normal in this stage, and RBC is normocytic normochromic. Stage 2, iron deficient erythropoiesis. Serum ferritin is decreased, TIBC is increased, serum iron and aspirin saturation is low, RBC normocytic normochromic. Now come to the stage 3. This is the stage of anemia. Iron deficiency anemia, ferritin low, TIBC increase, serum iron aspirin saturation low. In the early stage, RBC normocytic normochromic. In the advanced stage, it is microcytic hypochromic. Now come to the causes of iron deficiency anemia. Decreased supply of the iron, increased demand of iron, excessive loss of iron. Under the heading of decreased supply, it is inadequate diet, malabsorption like tropical flu, Crohn's disease, gastric surgery, acute or chronic inflammation. Increased demand, infancy, adolescence, pregnancy during erythropoietin therapy. Excessive iron loss may be due to chronic blood loss, menstrual excess blood loss, acute blood loss. Come to the treatment. Oral iron therapy. Under the heading of oral iron therapy, we can think about the following points. The preferred for mild to moderate deficiency, 150 to 200 milligram elemental iron daily in 2 to 3 devices doses. Duration of treatment 3 to 6 months for anemia correction, although it depends upon deficiency. Once the anemia is corrected, treatment should be continued for another 6 months to fill up the iron store. Ideally should be taken in empty stomach as food interferes absorption. Nausea and constipation are common side effect. Common iron salt with corresponding iron, elemental iron, ferrous sulfate 325 milligram, contain elemental iron 65 milligram, ferrous fumarate 325 milligram, elemental iron 107 milligram, ferrous gluconate 325 milligram, elemental iron is 39 milligram. Parenteral iron therapy. Indication for intravenous iron therapy. Unable to tolerate oral iron. Needs are relatively acute. Need iron on an ongoing basis as in persistent gastrointestinal or menstrual heavy loss during erythropoietin therapy where a large demand of iron is produced. Iron requirement calculation. The formula is body weight in kg into constant factor 2.3 into 15 minus patient hemoglobin in grams per deciliter plus 500 to 1000 milligram for store replacement. Common parenteral iron preparation with elemental iron per infusion, peromoxitol, elemental iron 510 milligram, ferric carboxymaltose, elemental iron 750 milligram, iron sucrose, elemental iron 200 milligram. 500 to 1000 milligram elemental iron is given in 1 to 2 sessions in a week. Side effect arthralgia, skin rash, low grade fever, rarely anaphylaxis. Next is red blood cell transfusion. Indication severe anemia when hemoglobin 7 to 8 gram per deciliter, cardiovascular instability having shortness of breath, tachycardia, extreme weakness, continued and excessive blood loss. 1 unit of plant cell transfusion can raise hemoglobin 1 gram per deciliter. This is the picture of anemia of chronic inflammation, chronic disease and CKD. What we see, it is kidney secretes erythropoietin which acts over the marrow for production of RBC. What happens in chronic inflammation? In chronic inflammation, there is liberation of cytokines. These cytokines act over the kidney as well as in the bone marrow. So, these cytokines inhibit kidney to produce erythropoietin and also inhibit bone marrow to inhibit erythropoietin action. So there is less formation of RBC. On the other hand, this cytokine act over the liver for liberation of hepcidin. This hepcidin acts over the duodenum jejunum from where the iron is absorbed, and also act over the reticuloendothelial iron store where iron is absorbed for the bone marrow. So there is less absorption of iron from this side. So net effect is decreased production and action of erythropoietin and insufficient iron supply in the marrow from these sides. So this is in summary the pathogenesis of anemia of chronic inflammation. Now come to the right side of the picture. Here we see the erythropoietin is secreted from the kidney and acting over the marrow. What happened in chronic kidney disease? This erythropoietin is producing less in quantity, so there is decreased production of erythropoietin causing decreased RBC production in chronic kidney disease. Now come to the differences between the inflammatory anemia and iron deficiency anemia. As I have discussed in the earlier slide, according to the percentile distribution, commonest is the iron deficiency around 50 to 60%, and next is the inflammatory anemia. If you sum up these two anemia, it covers around 75 to 90% of the total anemia. So we have to know better about the iron deficiency anemia and inflammatory anemia and their differences. So what happens in inflammatory anemia? Anemia is mild, but iron deficiency anemia it is mild to severe. Morphology of the RBC in inflammatory anemia it is normocytic. In iron deficiency anemia it may be normocytic in early stage, but in the advanced stage it is microcytic. MCV in inflammation 80 to 90 femtoliter. In iron deficiency it is 60 to 90 is normal to low. Serum ferritin in inflammation 30 to 200 microgram per liter it is normal. In iron deficiency is less than 15, it's very low. TIBC in inflammatory anemia it is less than 300, but in iron deficiency anemia it is high, more than 360. So serum ferritin differentiate between the true iron deficiency anemia and iron restricted anemia of inflammation. Treatment of anemia of inflammation or chronic disease. First is the treatment of the underlying disease. Next is the transfusion if hemoglobin is less than 7 to 8 gram per deciliter, causing cardiovascular compromise, and the target hemoglobin is roughly around 11 gram per deciliter. Erythropoietin useful when it is low, as in chronic kidney disease and inflammation. Usual dose 50 to 150 unit per kg subcutaneous or IV, usually 2 to 3 times a week. Iron status must be reevaluated and iron store must be replaced for optimal effect of erythropoietin. Next come to the megaloblastic anemia. Deficiency of the cobalamin and folic acid or drug that interfere the folate metabolism are the causes which result in defect into DNA synthesis in rapidly dividing cells like marrow. Cobalamin, it is vitamin B12, only source of human is food of animal origin, that is meat, fish, dairy products. Adult daily dose 1 to 3 microgram. Absorption occurs through ileum with the help of intrinsic factor. Causes of deficiency: vegans, pernicious anemia, where gastric atrophy due to antiparental antibody resulting into lack of intrinsic factor, total or partial gastrectomy, ileal resection, tropical flu, Crohn's disease, long-term metformin therapy, fish tapeworm. Diagnosis of cobalamin deficiency: normal serum cobalamin 200 to 1000 nanogram per liter, less than 100 nanogram per liter is deficiency. Treatment: 1000 microgram hydroxycobalamin injection 3 times a week for 5 to 10 doses, and then maintenance doses 1000 microgram every 3 months lifelong. Last daily oral dose of cobalamin 1000 to 200 microgram is useful for pernicious anemia. Come to the folate, highest concentration found in the liver, yeast, peanut, other grains and nuts. Adult daily dose 100 microgram. Absorption through jejunum. Causes of deficiency: when there is excessive requirement, as in infancy, old age, pregnancy, lactation, tropical screw, Crohn's disease, gluten enteropathy, pathological excess demand and hemolytic anemia, carcinoma, antifolate agent use, barbiturate, alcohol, phenytoin, antifolate drugs which inhibit diet-to-folate reductase inhibitor like methotrexate, trimethoprim, and pyrimethamine. Diagnosis: normal serum folate level is around 2 to 50 microgram per liter. Treatment of folate deficiency: 5 to 15 milligram per day. Before last dose of folate is given, cobalamin deficiency must be excluded and if present be corrected, otherwise neuropathy may develop. Clinical features of megaloblastic anemia: many are symptomless and detected through the findings of raised mean corpuscular volume on routine blood count. Anemic symptoms: other than anemic symptom is anorexia, weight loss, diarrhea, angular cheilitis, glossitis, thrombocytopenia may be present. Associated features related to the folate deficiency is infertility, prematurity, recurrent fetal loss, neural tube defect like anencephaly, meningomyelocele, encephalocele, and spinobifida. When related to the cobalamin deficiency, it is peripheral neuropathy, demyelination of the posterior and pyramidal tract, resulting into muscle weakness, difficulty in walking, psychosis, and visual disturbance. Hematological finding: oval macrocytosis, MCV more than 100 femtoliter, anisocytosis, and poikilocytosis. Neutrophils are often hypersegmented with more than 5 rows. In the picture, we have seen that oval macrocyte RBC are present. Come to the hemolytic anemia. Under the classification, first is the hemoglobinopathy. Under this heading, it is thalassemia and sickle cell anemia. Enzymopathy like GCSPD deficiency, membranopathy, hereditary spherocytosis, elliptocytosis, others, paroxysmal nocturnal hemoglobinuria, hemolytic uremic syndrome, microangiopathic hemolytic anemia, autoimmune hemolytic anemia, toxin infection like malaria. Features of hemolytic anemia: splenomegaly with hypersplenism effect, that is neutropenia, thrombocytopenia, sometimes hepatomegaly, jaundice, usually unconjugated bilirubin. This is the cause: gallstone, pigment stone, LDH high, haptoglobin reduced or absent, MCP usually increased, normocytic to mild macrocytic RBC, anisocytosis, poikilocytosis, polychromasia, and reticulocytosis. Other few specific cells are specific for specific types of hemolytic anemia. Let us discuss about the normal hemoglobin structure. In the tetramer of the hemoglobin, two alpha globin chain and two beta globin chain forming the normal hemoglobin A. Tetramer of two alpha globin chain and two delta globin chain forming hemoglobin A2. Tetramer of two alpha globin chain and two gamma globin chain forming the hemoglobin F. Normal hemoglobin distribution according to percentage: hemoglobin A 95 to 98%. Hemoglobin A2 2 to 3.5%, hemoglobin F less than 1%. Hemoglobin F level tend to rise in thalassemia and sickle cell anemia due to deficient or defective globin chain synthesis of hemoglobin A. Hemoglobinopathy is the thalassemia beta, decreased beta chain synthesis, and hemoglobin S, defective beta chain synthesis. Sickle cell patients are protected from severity of the falciparum malaria due to insufficient space for the malarial trophozoite development in the sickled RBC, as well as early recognition and destruction of the RBC by the spleen, causing parasite clearance. Let us discuss about the thalassemia major. Reduced supply of globin chain resulting into diminished production of hemoglobin tetramer, causing hypochromia and microcytosis. Lack of beta chain causing highly insoluble in unpaired alpha chain, which form the toxic inclusion bodies. This burden of RBC are detected by the spleen, resulting into RBC destruction and severe hemolytic anemia. Extra burden on the marrow, causing marrow hyperplasia, causing maxillary prominence with frontal bossing, the chipmunk faces. Extramedullary hematopoiesis in the liver and spleen can cause hepatosplenomegaly. Features of hemolytic anemia as hepatosplenomegaly, leg ulcer, gallstone like kidney stone, unconjugated hyperbilirubinemia causing jaundice. Chronic blood transfusion in beta thalassemia major causing iron overload, which may be fatal by the age of 30. Hemoglobin electrophoresis show increased fetal hemoglobin and hemoglobin A2. Peripheral smear showing microcytic hypochromic RBC mimics severe iron deficiency picture with target cell, teardrop cell, anisocytosis, poikilocytosis, and increased reticulocyte. Beta thalassemia minor shows mild anemia, but the peripheral blood picture mimics iron deficiency anemia. Let us discuss about the few slides related to the beta thalassemia major. This is the slide showing variable separate RBC, that is anisocytosis, and variable separate RBC, that is poikilocytosis. In this slide, we see the bullseye appearance or target cells, target cell RBC with dark center, say the teardrop separate RBC. See here the reticulocytosis, increased reticulocyte in the peripheral picture is typical of hemolytic anemia. The splenomegaly, frontal bossing with zygomatic and maxillary prominence, chipmunk cases. Let us discuss about the sickle cell anemia. Defective beta globin chain synthesis due to replacement of amino acid glutamic acid by the valine in sixth position causing severe anemia. Confirmed by hemoglobin electrophoresis. When hemoglobin is deoxygenated in annular capillary, hemoglobin S polymerases reversibly to form a gelatinous network that stiffens RBC to produce stiff, sticky, and viscous, which is difficult to pass through the venular capillary. As a result, there is tissue and organ ischemia and microinfarction, episodes of painful crisis and priapism. Provocative factor for painful crisis, excessive exercise, fever, dehydration, emotional change, abrupt changes in temperature, and hypoxic state. Organs affected, spleen, autosplenectomy, usually by the fifth years of age due to repeated microinfarction, liver, kidney, lungs. In lungs, it is acute chest syndrome causing tachypnea, fever, cough, mimic pneumonia, bones, joints, retina, and sometimes native central nervous system. Features of hemolytic anemia as is hepatosplenomegaly, leg ulcer, pigment gallstone, unconjugated hyperbilirubinemia causing jaundice. Most painful crises resolve in 1 to 7 days, can be managed at home with vigorous oral hydration with analgesia. Antibiotic prophylaxis in minor operative procedure as the splenic function is lost in early age. Pneumococcal vaccination should be done before autosplenectomy in this patient because spleen is the one of the site for B cells antigen recognition. Hydroxyurea 10 to 30 milligram per kg per day may be useful for sickle cell anemia to decrease the fetal hemoglobin. Here is the picture of sickle cell. The sickling of the RBC are shown here in two slides. Discuss about the G6PD deficiency. It is X-linked transmission. Vast majority of the patients are clinically asymptomatic throughout their lifetime, but all are increased risk for acute hemolytic anemia when challenged to oxidative agents. Triggers for hemolysis, drugs, and infection. Under the heading of drug, it is primaquine, dapsone, sulfamethoxazole, nitrofurantoin, and few others. Hemolytic attack starts with malaise, weakness, abdominal pain. Acute renal failure is the most serious threat of acute hemolytic anemia. RBC pattern are same as typical hemolytic anemia. However, hemigo cell, white cell, blister cell are typical for G6PD deficiency. Our aim is to avoid the exposure of triggering factors. This is the picture of white cell. Hereditary spherocytosis, 1 in 5,000 population. RBC are usually sensitive to hypotonic solution, resulting into lysis. This is the basic of osmotic fragility test. Spherocytic cells and treatment with the splenectomy. In this slide, we see here the spherosphere 7 RBCs. Let us discuss about the paroxysmal nocturnal hemoglobinuria. The pathology is RBC lack CD55 and CD59 protective protein, which makes it sensitive to complement mediated destruction, triad of pancytopenia, venous thrombosis, and hemolysis. Most patients are young, passing blood in early morning instead of urine. Without treatment, median survival 8 to 10 years. Flow cytometry is the gold standard for diagnosis, treated with transfusion, iron, folate, eculizumab. Transfusional hemosiderosis, 1 unit of RBC contains 250 to 300 milligram iron, equivalent to nearly 1 year oral intake of iron, considering daily elemental iron intake 1 milligram. Patients who receive more than 100 units of packed RBC usually develop hemosiderosis with rise of serum ferritin level, as iron has no mechanism of excretion. Endocrine dysfunction, delayed puberty, glucose intolerance, cirrhosis, cardiomyopathy. Parenteral deferoxamine or old deferoxirox 20 to 30 milligram per kg per day are useful as treatment or prevention. Come to the bone marrow insufficiency, aplastic anemia, pure red cell aplasia, myelodysplastic syndrome, myelophthisis, or myelofibrosis. Aplastic anemia, pancytopenia with marrow hypocellularity, causes are idiopathic, the commonest viral infection, drug like cytotoxic drug, chloramphenicol, NSAID, anticonvulsant, sulfonamide, lithium, etc., radiation therapy. Features of thrombocytopenia are the most common early symptom like petechiae, purpura, ecchymosis, and easy bleeding. Anemia is the next common feature, but infection is unusual first symptom. Blood smears show large RBC, increased MCV with paucity of platelets, marrow show fatty biopsy, hematopoietic stem cell treatment, transplant is the treatment. In this slide, we see a blood picture, peripheral blood pictures, complete blood count of a patient of iron deficiency anemia. See, it is the hemoglobin 4.7 gram per deciliter. Look at the packed cell volume, it is 19, whereas normal is 40 to 50. It is the mean corpuscular volume, it is 51, it's less than 80. So it is less, it is microcytic nature. Mean corpuscular hemoglobin 9.4 is less than 27. Mean corpuscular hemoglobin concentration 18.4, so it is less than 31. Serum ferritin just 1 is very low. Peripheral picture microcytic hypochromia. From the above discussion, we can say that MCV is low, MCH is low, MCHC low. MCV low means it is microcytic, MCH and MCHC low means it is hypochromic, and serum ferritin is low. So this is a case of iron deficiency anemia. As the picture also shows, there is a microcytic RBC. Take home message: any patient with fatigue, weakness, shortness of breath, palpitation, or anginal pain should be investigated for anemia. Commonest anemia is iron deficiency anemia, 50 to 60%. Next is the anemia of chronic disease. As per WHO, hemoglobin less than 12 is female and less than 13 in male is anemia. MCV determines the RBC size. If it is less than 80, it is microcytic, more than 100 is macrocytic. MCHC determines the hypochromicity of RBC, less than 31 is hypochromic RBC. In the early stage of iron deficiency, RBC is normocytic normochromic, whereas the advanced stage is microcytic hypochromic. While thinking about the iron deficiency anemia, always look for the serum ferritin for confirmation. Determination of the reticulocyte production index help in determination of the hyperproliferative and non-hyperproliferative marrow response to anemia. If RPI more than 2, it suggests hyperproliferative. high response which may be due to chronic hemorrhage or hemolysis. Anemia with splenomegaly, always think for hemolytic anemia and myelofibrosis. Normal daily requirement of elemental iron 10 milligram in male, 15 milligram in female, of which only 10% of oral elemental iron is absorbed. In iron deficiency anemia, correction is 150 to 200 milligram per day elemental iron usually corrects the anemia. In 6 months and another 6 months are needed to replenish the iron store. Normal daily requirement of cobalamin 1 microgram, but when deficiency is detected, 1000 microgram parenteral hydroxycobalamin or 6 to 10 doses followed by maintenance dose 1000 microgram every 3 months. Normal daily folate requirement 100 microgram. Once deficiency detected, 5 to 10 milligram per day for correction. Thank you to all.